We'll move on to the next topic, which is overcoming challenges to treatment adherence. It's a great pleasure to formally introduce Zeba and Jeff. So Professor Zeba Aziz from the Hameed Latif Hospital in Pakistan is our regional expert, great friend of the foundation, a relationship that started when she did a clinical preceptorship via the foundation with Brian Drucker a few years back. She is also on the Foundation's South Asian Steering Group. She's a tour de force at meetings and discussions and always there when I need to know anything or find someone in South Asia. She's very witty, has the best turn of phrase, great leader, always generous with her time. Zeba, thank you so much for joining us. And last but never least is Dr. Jeff Lipton from Toronto in Canada. Jeff is another giant in the field and my go-to person for the really difficult cases, the questions that have other people shaking their heads and not responding to my emails. He really is just the greatest support. He keeps telling me he's trying to retire, but I always just hope that means he has more time to continue to do jobs like this with the foundation and events like these. Such a privilege to have you here again, Jeff. Welcome.
I'd just like to give you a brief background on the epidemiology data and what the socioeconomic status and education is all about in low middle income countries. And I'm using Pakistan as a prototype, which I'm sure, and this is what we have. The prevalence of CML is about 1 to 2 million in males and 0.6 million in female. The median age at presentation is again 46 years. If TKIs are taken regular, we know there's a great impact on the life years saved. We have shown in our previous studies, which have been published internationally, that survival is similar to that reported from the West. The Max Foundation initially started the Access program, which was a great success as the drugs were free and the Max Foundation provided extensive education. Because of that initial foundation, more and more patients are now presenting in chronic phase CML. Over time, Max Foundation phased out because of the high costs of the drugs which were provided by Novartis. Now, if you look at the socioeconomic status in Pakistan, the average GDP per capita is $1,700 US. A daily wage worker will earn $145 per month, and he has to feed an average family of 6 or 7. The multidimensional poverty index is about 38.3%, and another 12.9% people are vulnerable to poverty. The lower middle income socioeconomic status is about 16.5%, which live below $3 a day, and 44.7 live with below $4.2 a day. I've given you the cost of the drugs from Novartis and the generic drugs which are being made in Pakistan. And the cost is remarkably different here. The population of Punjab is the region where I am, is 127.7 million. And there are currently 5 CML centers which are run in government hospitals which provide drugs free of cost. Total approximate patients is 5,000. Generic drugs are being used. And now, instead of senior doctors running the clinics, they're the junior doctors where they see 50 to 75% the patients per clinic. The education on efficacy, adherence, discussion on psychosocial stigmas, side effects is hardly done. Other than providing drugs, the lab and the supportive medicines are not provided by the government. So I'd like to present, and if we look at treatment adherence in CML, poor adherence and not resistance is the leading cause of treatment failure in our part of the world. And they do not take the drugs because it's a lifelong taking of a TKI, and there is very few people go on a TFR. The financial hardship a patient faces is the drug cost, supply gaps, travel to tertiary care centers to get the drug. Health illiteracy, which is one of the major problems which we have, online misinformation, poor understanding of why they must be taking daily, side effects which are rarely disclosed voluntarily, and the junior doctor does not have the time to listen to it. Family obligations, cultural norms, fear of being called sick and not getting married or whatever. But these are all facts which we have to deal with in our part of the world. Few the travel again, these are things. Test few treatment centers, where free drug is available, travel time, illiteracy, financial hardship. Supply chain interruptions are frequent. Testing for response to fish RQ-PCR is out of pocket. As a result, patients really don't do it. So, with this background, I would like to present my first case, which is a 28-year-old male factory worker from a nearby village in Lahore who was diagnosed with chronic phase CML. He travels 100 kilometers to access the CML center. He's married with 3 children and works on a minimal daily wage, which I've shown you. And his so-called score is intermediate. At 12 months, somehow he got a BCR-ABL done, which had risen in the past few months, and he lost his MMR. He had been taking imatinib every other day for 4 months, as he felt reasonably well. And since he could not access the cancer center frequently and could not afford to lose his wages, he decided to take it every other day so that it would light. He also had nausea and occasional abdominal cramps, which limited his physical work as he was a laborer, and he stopped taking his medications on and off. He still felt well. For this patient, the limitations which we face included financial barrier, lost wages on traveling. The doctors insisted that labs have to be done. And for the abdominal pain, nausea, and vomiting, he had to go and see someone, and supportive medications were. The side effect burden, which the junior doctors did not hear, went undisclosed, and the treatment was interrupted. There was a big communication gap and a system failure, which we have to accept that it is there. Okay, so basically, this is what it is. And if you look at the second case, it is also facing the same problem. 64-year-old female who lives in a very remote village. I'm sorry. Some doctors started her on nilotinib 300 milligrams BD, one of the junior doctors, for 18 months. She was widowed, she was illiterate, and she had to travel 3.5 hours to Multan for each appointment. She was dependent on her son, who was another daily wage worker, to bring her there. What happened? She lost her MMR. Her neighbor, who was also diagnosed with CML and was equally poverty-stricken, they shared their drugs together to prevent them from coming every 2 months, and so that the drug could last 4 months. She could not take fasting nilotinib as she had diabetes, so she started taking the drug whenever she felt like, and did not understand the risk of under or over treatment. Again, her problems included family obligation. She could not ask her son, who had about 5 kids, to leave frequently for her safety. Due to poverty, she could not afford supportive medications, as her diabetes got worse on nilotinib. There was no access to a nearby cancer center. She could not read and therefore missed appointments, and the physician support was minimal. These are problems which we face regularly, all the time. I'm not sure what the answers are, but this is what is happening. And that is why I asked the question, should we not put the patients on imatinib first rather than going on second generations, which have their own side effects, especially for older people, and in our poor segment of the society, where we know that the PCR is not going to be done regularly? And how do we overcome physician support? Thank you.
Thank you, Zeba. Jeff, would you like to start?
I think we're looking at 2 fundamental problems. One is the individual patient problem, which may be the individual patient doctor problem. And the other issue is the societal, the socioeconomic issues. In terms of the socioeconomic issues, I don't know what anybody can do in their locale, wherever it is, whether it's my country or your country, to change what is reimbursed, the priorities for what reimbursed, things of that nature. look, a country has to decide whether they want to fund medications, whether they want to fund building roads, whether they want to fund their army, whether they fund whatever. But the balance has to be that the money has to be there. If they're not going to do that, you can't bring some of these things like drug costs and monitoring things out of the woodwork. It's not going to happen. The other thing I think is important to realize, although many countries were blessed with the support from places like the Max Foundation, that's not a bottomless pit. Eventually, things have to be taken over locally. And especially as more expensive drugs come in, where limited money is gobbled up by fewer patients. So, those are the social economic things, which I don't think you or I else can do anything about. So, let's look at what we can actually do with that patient. I made some comments earlier on. Let's look at the first one. I think there's a number of things that could have been done here. Is number one, as I pointed out, the patient probably doesn't have to travel all the time. Number one, if they have a guaranteed supply of drug delivered to where they are, monitoring can be sent in if it's available in the Gary Radich filter paper technique to look at it and do things that way. A phone call if it's possible to look at side effects if it's going on. If the patient's not going to be honest with you, it doesn't matter if they're in Karachi or they're in Toronto or London, they're not going to tell you about problems. And that's much the issue, specifically if there are other options not available. So I think that's where you can reduce things like lost wages. If you know about their side effects, you can deal with things. Nausea and abdominal cramps were always side effects we had with the could be dealt with perhaps by changing how they take the drug, or they take it on a full empty stomach when they're taking it, etc. With other foods, cramps can be dealt with things as simple as tonic water. Yours is the part of the world where tonic water and gin and tonic were invented by the Brits, and that's where controlling cramps was a very important issue. So you can deal with a lot of from a distance. The patient doesn't have to travel. So you have to be able to communicate. If the patient isn't going to talk, that's fine. You can't do anything. I think this case was good. They started with the lowest drug possible. If the patient has a good response, there's even some evidence out there, Jane may or may not agree, that sometimes dosing can be reduced ever so slightly from 400 down to 300 once the patient has got a very least MMR. So there are things that can be done at the individual patient level. But A, you need resources. B, you have to have open communication with the patient. And it's got to be really enforced that it's not a shame to tell about side effects. Telling your doctor may help them and avoid the travel issues. They don't have to physically be seen, but monitoring can be done in another way. So that's case one. Jane, anything additional?
No, Jeff, I think you covered it very well. I guess what I don't know, I mean, Jerry Radich has obviously done an amazing job with his blotting paper, but you do have to have a good lab that can extract RNA from the blotting paper. So that may not be practical, but maybe one resource is that you set up one center in the country that can actually do it. We have a lot of samples sent in to us by the post. As long as we get it within 48 or 72 hours, we can normally get decent RNA out of it and actually get a reasonable result. It's so difficult, isn't it? Because your junior doctors are seeing a lot of patients, although we see 50 people in a morning, so 50 to 75 during a whole day. I suppose it depends how many junior doctors you've got. It's all about educating them and just getting them to ask about side effects, I guess. Just constantly reminding the doctor that there's no point prescribing a drug if it's not going to be taken because the patient has a side effect and has decided to abandon it. That's also a huge waste of money. But otherwise, Jeff, I think you covered it. We had to fight like crazy in the UK with the Department of Health to get drugs sensibly in the UK. So you should never give up fighting your local health service. But I know that it's incredibly frustrating when there's a lot of other demands on resources.
No, the patient numbers are phenomenal, and that's a large number. I remember a number of years ago, maybe a decade, I did rounds at Ames in Delhi, and there were about 100 people in the waiting room, and then a lineup went out the building and around the building 3 times waiting to get in.
Yeah.
It was the numbers are low. And when you tell me 5,000 patients in a population of 1.125 million, I'm wondering how many people are not being seen.
Yeah, absolutely.
I wonder how many people are not being seen. That seems to be a very low for that number. I don't know what the incidence of it in Pakistan, but I've been told in India there's 50 to 100,000 new cases a year of CML. So wow.
Wow. Stalin, would you
Second
like
thing.
to comment on case 1, and then we might move on to case 2?
So
Stalin?
yes. So regarding this problem in Indian context, so this has been largely been rectified over a period of at least 4 to 5 years, because majority of the times with availability of more and more CML physicians and availability of the generic imatinib, this and the cost has been significantly reduced, and under the government schemes majority of the patients are still getting, even beyond the GPAP, majority of the patients are getting the at least imatinib at free of cost. So at least all the CML patients in India are able to receive the frontline imatinib, and majority of the times these adherence issues regarding the frontline usage of TK has been sorted extensively. The only thing which has been not sorted in this part of the region is the rigorous monitoring, which is according to the ELN guidelines, that once quarterly or once in 6 months, because we tend to do at least for the first year, we tend to do it 3, 6, and 12 months. But after that, once the patient attains MMR, so majority across various institutions and practices, we tend to do it at least once in a year. But the biggest challenge is in the second and third lines, where the usage of the second generation TKs and the third generation TKs becomes costlier. But the frontline management CML across all parts of the India has been well planned now, because imatinib is available under the state-sponsored schemes and the central government schemes for the free of cost to the patients who are not able to afford it.
Aaron makes a very good point. And one thing is the better your adherence and everything with frontline therapy, with cheap imatinib, the fewer patients you're going to have who will require the more expensive second or third line. It makes a big difference. So the money should be put at the bang at the first line. And that, you have to deal with the second. I'm not saying don't deal with it, but you reduce that problem with adherence in front line.
Jeff, the problem
Second
is
case?
not that the drug. Yeah, okay.
No, Zeba, come in and
You
give
wanna
us
go
your
this-
thoughts.
Yeah, I'm just talking about a patient who is having a generic imatinib, but does not have the support services, which Jeff pointed out, is that we should mail the drug to that person rather than making him come to the treatment center, which are only 5 for a population of this big. So it is not a question that the generic imatinib is not available. It's a question of the physician coming, a patient coming, and the physician not taking time to see the side effects, which I don't blame the physician. He has a 3-hour clinic, and in that 3 hours, the 75 patients are seen by one physician. So it's both a problem.
This is where support workers help, and there's been a lot of good data, particularly
Yeah.
that has come out of places like Korea and China, about using nurse practitioners
Patients.
and good trained nurses to be able to contact patients and discuss these patients and then communicate problems to the physician. It does not necessarily have to be directly patient to doctor. There's a lot of support staff that you can use to help you with this. And our nursing colleagues in that, or even pharmacists in some cases, are very good. Setting up distribution centers across the Punjab So maybe it's no more than half an hour or an hour's trip to a center for all these people, where drugs will be centrally set up is one thing that can be done.
That I agree with.
Yeah, I would say that our CML nurses and pharmacists, I don't want to be disrespectful to our junior doctors, but I would say that well-trained nurses and pharmacists are better than a junior doctor.
Amen.
Might be a good point to
Jane,
wrap
one
up
of the
that case. Any further
Please do.
comments on this
Yes.
case? Go. Any further comments on this case, or would you like to move on to case 2, Zeba?
Yeah, you can.
There we go.
So I don't know, is it the right time to come in, Arlene? This is Hemant Malhotra from Jaipur in India.
Yes, please, Hemant. Welcome.
Yeah, so thank you, and lovely to meet Jane and Jeff, my dear friends, and of course Zeba and Stalin, and wonderful discussion. And I think Zeba, I completely understand the problems and issues which you're going through, which we did about 15, 20 years back. But as Jeff and Jane both said, we have to use all the resources at our disposal to at least have one or two first generation and one second generation TKI in every government hospital drug formulary, and it's a constant battle. The second thing, which the uniform message which I got across from you and from so many other centers and
You're on mute, Hemant.
Come back, Hemant.
can you hear me?
Yes, we can now.
Okay, I'm sorry. It's something. So we have to develop our medical college hospitals, and each one of them has to do the BCR table testing on the international scale. In fact, the medical college in Jaipur, where I was earlier, they are doing a BCR table, and it's absolutely free for the patient, zero charge. The government bears the charge. So it's a struggle. I do understand that, but we have to keep pegging at it. And as Jane was saying, like it took a long time for them to get to where they are just now. And we just have to go on and on and on because I think the benefits of the TKIs should reach each and every single patient of CML over.
Absolutely. Thank you for that contribution, Hemant. Always good to hear from you. Jeff, would you like to open comments on case 2?
Okay, case 2 is very interesting. I guess the first issue I have is I'm not sure why a patient with diabetes was started frontline on nilotinib. That bothers me. It bothers me a lot. And that to my mind, probably shows some misunderstanding or lack of knowledge on perhaps the treating physician, in that diabetes and worsening diabetes are really risk factors in nilotinib. If all you have is nilotinib and imatinib should be the drug of choice for this individual. And obviously, this has resulted in some problems. Stories you tell about sharing medications because not being able are not unusual. This goes on all over the world. I can recall talking to a physician in Colombia whose patients got their imatinib in those days from the government and then would sell 1 month of it a year on eBay in order to make money to support everything else. It's a really an issue. I think a lot of this is things we've discussed is distribution centers where they're in local hospitals to avoid the travel, having extra health workers deal with the patient issues in discussion, monitoring through either blood samples sent effectively, as Jane has mentioned, or if the filtered technique is working, are very important. I think communicating are very important with the individuals. And I think these are things that can be dealt with. I don't know if it's been tried in Pakistan, but is it possible to have a consensus group that supplies a game plan, a business plan to the government? as a group, not as each individual, but a business plan. You say, this is the number of patients we have who are being diagnosed in Pakistan. This is the patients on therapy. These are the problems we have. We want to set up a system. Well, obviously, more doctors would be nice, but train nurses to talk to the patients, distribution centers where they can get generic drugs free, first line, and ways in the case of the less frequent patients who need to move on, something else. But treat this as a business, not as an individual physician trying to fight. Give your government a business plan. I think this should happen. You know, if the government becomes aware of the magnitude of the problem, and actually a good business plan will probably tell them it's cheaper. Because I don't know what you do with a patient who goes into blast crisis where they get into hospital and get acute leukemia therapy or go on to something else. That's costly too, and things that you can avoid. So I think, yes, you can advocate on an individual basis. You can try and advocate locally to communicate with the patients, but I think you need a national business plan for how to deal with this problem.
Zeba, I think you might come in and respond to some of those initial questions about frontline nilotinib and then some of Jeff's suggestions, please.
Okay, Jeff, I totally agree with you that why was this patient started on nilotinib, and I couldn't figure out why. But what I find is that the education of when to start a second line therapy and a therapy with side effects has to be taught to the junior physicians. Now, nilotinib is free of cost compared to dasatinib or anything else. Why she was started on nilotinib, I don't know. What you're suggesting as a business plan, we have already discussed it, that the physicians in Punjab, where imatinib and nilotinib is being provided free of cost, they have to get together and streamline how to prescribe medications, when to monitor, and save the government more headache and treat the patients properly. As far as nurses are concerned, the nursing staff is very in the government center. I'm not sure if they could handle, unless we have one dedicated nurse, which is very rare to handle all this stuff. Another thing is we are planning to have a telemedicine clinic with these patients every 2 or 3 months, and telling the government that the distribution centers which they have should have these drugs there and mail it to them, so that they don't waste their resources on just coming to the city. One of the problems which we faced initially was, this was in the initial times when Max Foundation was there, that patients had started selling their drugs. And we had asked them to bring the strips back so that we knew that they were taking it. But we can do that again, but I don't know how effective that will be, because they are either not. For them, for us, adherence is one of the major problems with these drugs. And we have, in fact, all the doctors have gotten together to share how to access these problems. Since these cases were being presented, I presented them that is what is happening long term. But as you had suggested, we already have been planning to have a meeting with the government, all 6 centers, and see what happens.
I want to caution you. I think to say necessarily junior doctors, I think a lot of where even senior physicians get their information on what drugs to use may not necessarily be good through education, but there's often a lot of pushing and publicity, particularly when there's limited drugs. So let's leave that. I think don't underestimate your nurses. Please don't some of them are a hell of a lot smarter than some of us physicians, and they do a good job, particularly if they have a very focused approach. They know what to ask, they know how to deal with patients, they know what to report. So that is something we all have paternalistically have tended to do in the past, but we probably should not be doing.
Okay.
Yeah,
Thank you, Jeff. I might invite Jane into the conversation. And as you talk, Jane, just if the audience have a look at the comments coming up in the chat, just some interesting issues to consider. Jane, please go.
Thank you, Ollie. In fact, it was a comment about something that's been put in the chat, which is about AI tools. Now, you're describing patients who are extremely poor and are illiterate. So I'm not entirely sure how the AI tool helps them. I'm sure if you're very clever, you can devise cartoons and things, but you have to have access to the internet and a decent phone and things. But what about just thinking about this patient being started on nilotinib? What about AI for the junior doctors? So I know they're busy, but if they press a button and on their phone comes up new diagnosis of CML, start imatinib, it's very hard for them to start nilotinib.
Jane, you're absolutely right. But Jeff alluded to another problem, which was the access of the new drugs and pushing by the drug companies of this drug is better and this drug is not better. Now, the poor old imatinib has been relegated to the rare waste basket by some of the physicians because of so much pressure and so much, pressure by the pharmaceuticals and otherwise to prescribe the newer drugs. I don't want to say, but this is one of the problems which we face, and imatinib has gone out of fashion, so to say. For this woman, that would have been the best drug to use, and with her diabetes, with the least side effects, she could have maintained herself. But with nilotinib, she just freaked out with her diabetes. And I think we can't exclude the pressure from the pharmaceuticals for the younger doctors who are just on their way up for prescriptions. So whether we like it or not, it's a fact of life which we are living with.
Well,
I'm amazed they have time to talk to drug reps.
Yeah. Oh, they found time. One thing you can do in a lot of jurisdictions is you can put in guidelines about what can be used. So that someone can, if the guideline is, unless there's a damn good reason not to use generic imatinib front line, that's it. That's what you use. So that this outside pressure or anything like that is reduced. We've done that in Canada. We went through the same situation with the same drug, nilotinib, that everybody across the country was prescribing instead of imatinib until all the wheels came off the wagon and the problem was suddenly realized. So it can be dealt with.
I'm sure, but we have weak systems both in the government sector and in the public hospitals. Unlike what we see in the West, in the Canada and US and Europe. Yes, we can do it. We are planning to do it even now. Some of the centers are resisting that we should not use imatinib as first line unless we have no choices. So basically, it's a question of education. And the more you read about it, the more you understand that for us, this might be a better option than trying the newer drugs, more expensive drugs.
Well, and when you build in your business plan with what you're going to do and how you're going to do it, should include a cost analysis and a talk of what would happen if you use imatinib front line. This has got to do not in a committee, but a real business plan. Talk to someone in industry about how they do a business plan and see how it's done. Governments listen when you see balance sheets that show pluses and minuses and safety and things like that. If it's done the right way, the government takes notice.
Okay, we'll do it. Thank you.
I don't know what the relationship is like with your pharmacists. I don't want to sound judgmental at all, but our pharmacists are incredibly well organized and very highly respected. And if one of our doctors prescribes a drug that they don't think is indicated, they won't dispense it. So I don't know if you can involve pharmacists in your business case. Because if they won't actually hand the drug out, the junior doctor can't prescribe it, irrespective of the drug company pressures.
Nobody's allowed to question the doctor. I mean, if somebody has written it, the pharmacist is not going to question it. They'll give it because they have not seen the patient or the side effects or anything. And the patient is, or the family will just go and say, this is the prescription, please give the drug. So that way, there is a problem. But as Jeff said, we'll have to come up with a business plan and sort it out. And I think this is a very serious business.
Stalin, looking across the border, how do you see this?
See, in such cases, so my opinion is to go ahead with and start using imatinib, because a single pill a day definitely improves the compliance of the patient, especially for a 64-year-old. And in majority of the places in India, definitely that might be the best choice, even though there is a pressure from the pharmaceutical companies or whatever it is. So we tend to use imatinib across such cases, because for a 64-year-old, so there will always, majority of the times, will be a polypharmacy. Using a single pill a day, which has no relation to the food, definitely improves compliance and adherence in a resource-limited country like India.
Stalin, it's very easy to say that, but when you're practicing in different centers, you don't know what the problems are or how this slips. And this is one of the cases I picked up. So it's not necessarily that everybody is treated like that, but these are the, since adherence was a case discussion, I thought I'd put this up because
Yes,
I was,
yes, madam. Yeah,
and
yes,
you
madam.
know, everywhere across the border or in other countries, you will see these slip-ups being made where, due to pressures to whatever reason, a physician decides to put a patient on nilotinib. Now, whether that physician was right, wrong, there's no explanation for it. The patient doesn't know why she or he went on nilotinib or any other second-line therapy. And these slip-ups happen all over the world. It's not just Pakistan or India or
No.
Colombo or wherever.
Yeah, this happens
So
with us
it's
also. Yeah,
yeah, that's what I'm
all over
saying.
the
It's
world.
just a case which has been presented to discuss the problems which happen in low middle income countries. I mean, one could have given the best scenario, but that was not so. And because adherence was the topic I was allotted, I gave this case. And to discuss, frankly, the problems which we face, yes, we can all improve it. And I think Jeff and Jane's suggestions are very well
So
taken. That
in such cases, so what is your take on using a dasatinib at a lower dose, because there is a data for the
no,
50
the
mg, because that
satinib
can
or
also.
dasatinib and everything is available, but that is out of pocket. The government only provides free nilotinib or imatinib. That's it. And that is because Max Foundation set that precedence up. So we have suggested to them that there are other drugs which are less toxic for the older patients. And please add these if we are giving generic drugs.
Put
Thank
it
you.
in
So,
your business plan.
yeah, exactly.
Put it in the business plan. Because
I think
dasatinib at 50, generic at 50 milligrams to start, which works for most people, is a lot
Exactly.
cheaper than what you're
But
quoting for generic nilotinib.
Thank you,
yeah, but
everyone. Such a rich discussion. We could go on for hours and hours and hours, but unfortunately, we have gone over time. That was such a rich discussion and wonderful cases from both of our regional experts. Thank you very much to Dr. Jeff Lipton, Professor Zeba Aziz, Dr. Stalin Chowdhury Bala, and Professor Jane Apperley. And to our audience, thank you very much for being here. Thank you for your comments in the chat. If you have questions or comments that haven't been answered today, please send them to me by email, and I will get responses and answers to you. As you can see, we're very well connected.